Ahmed, you're going to present then on behalf of Mukta, yeah?
Yes.
Okay, very good.
So I apologize in advance if I'm not very familiar with the slide presentation, because these are not my slides. Even though I did try and go over them just to make sure that I'm familiar with what's there. So we start off with our case history. Our lady is a primate, low risk booking. She has a normal 12 and 20 week scan. Uneventful antenatal care up until 41 and 2, when she presents into triage at 6 o'clock in the morning with history of reduced fetal movements overnight. The CTG is commenced, and I mean, Joe and Fatima, I know you're the only two there. We are going to start off. What are we supposed to be expecting on the CTG as it runs? Where would we expect the baby's heart rate to be?
So she's post-date, so between 110 and 150, but probably on the lower side.
Yes. Okay. What about variability? What would you expect that to be?
5 to 25.
Yeah, so it should be normal.
Yeah, normal.
It should be cycling. Accelerations?
Yeah, should be some accelerations.
Possibly. Probably. Decelerations?
Wouldn't expect there to be decelerations, but there could be.
So her main presenting symptom is that baby's not been moving very well. She's not really saying that she's contracting. So this is the CTG when it first starts. Okay. What do you think about this?
Uterine irritability. Baseline is about 150. Variability is low. Doesn't look very good. I don't know why she's attracting like 6 in 10.
Looks like it. I mean, even though she doesn't seem to be complaining of contractions, but it looks like she is contracting 6 in 10.
Mm.
Okay.
Yeah.
So what do you think about the baby? How do you think this baby's doing right now?
I don't think the baby's doing very well at the moment.
And this is within 15 minutes of her walking onto our triage.
Yeah.
Okay.
Could this be seeing some kind of maybe chronic hypoxia or
possibly?
Maybe.
Anything else on your mind?
Well, with the uterus being so irritated, could it be something like abruption?
Potentially, yeah.
Concealed
okay. A concealed abruption. Okay. What about infection?
Yeah. Oh, equally, yeah, could be infection as well.
Possibly.
But just the reduced movements and no other symptoms, but no SROM or anything.
Yeah. So first on my list would be chronic hypoxia, and is there an abruption happening? Yeah.
That's very good, Joe, because the two things that you consider with this uterine irritability were exactly correct, which is thinking about the two things that irritate the uterus, which are blood and infection. And as you said, a baby that is post-dates, you would expect a baseline that is on the lower end of normal. And this one is about 150, isn't it? It's at the very limit of what you consider. What would be the thing that you could do to see what is normal for this baby? Because you don't know if the normal for this baby is 120, 130, 140, 150.
Check the antenatal clinic notes. Hopefully they've documented the FH.
Yeah, see if there's any previous CTG will give you another impression. Yeah.
Even if it's an uneventful pregnancy, just go into the heart rates in the antenatal clinic if there's no CTGs in the past, because she's low risk, she hasn't had any risk factors, she might not have had any CTGs. Go and look at what the FH was in clinic. Yeah, so that will also give you an idea or an impression of where the baseline should actually be. Okay, what do you think about this baby at the moment? Do you think this baby is okay, or do you think we need to rush and do something?
I'd definitely be escalating this. I don't think the baby's okay, but I don't know about yeah, because if at the moment we're thinking chronic hypoxia or abruption or infection, neither of those are particularly good in a woman who's not in labour. But I guess you just
Yes.
examine, check her,
Ish.
see if her uterus is hard or anything, see if you can get any more clues.
So the thing that you keep on going on, this woman is not in labor, this woman is not in labor. She's contracting 6 in 10. Can she be in labor? She's a primate, but she doesn't know what labor feels like.
That's true, I hadn't thought of that.
So 1, I would examine her to see how far she is. And 2, I can see that this baby is fairly flat. What about stimulating that baby and seeing whether this baby responds, to seeing where baby is at within the spectrum of the hypoxia, yeah? So great minds think alike. This lady was examined at 6:15. So if you can see my mouse, it's probably not around here. Okay, she's 1 centimeter dilated, station -2, membrane just intact. But you can see there's hardly any response, maybe a tiny squiggly, but that's pretty much what it is. What do you think? What do you think about this baby now?
I don't think
the baby's very well.
Yeah, I think this baby's in trouble. So yes, you were planning to escalate, which is why we need to actually escalate this a little bit faster. So Leopold and registrar are informed. Unfortunately, the registrar is busy in another room, but is informed of this is an urgent situation. So the registrar is coming. Okay. In the meantime, while people are coming from labor wards, what can we do? What do you think the outcome of this baby is going to be?
Can I just ask about, because Joe said something very interesting about escalation, and it's a big word, or it's a small word for a lot of things. I think that what escalation means for each one of us may be different, and the way we escalate and we communicate is probably the key thing. And escalation is only effective if we know why we are doing it. Is why we are doing it. And it is important when we communicate to say exactly what are we escalating. So what would be your, so because Joe, you went through you are worried. Yeah. It's okay to start by saying I'm worried. That's a very good way to escalate, I think. But just to escalate, to pass it without giving the sense of urgency or what is your perspective, or it's sometimes a bit useless, because people that has not seen the CTG will have 1 million things in their hands and will need to prioritize. So escalation stays a lot in the person that gives the information. Can I ask you whether on the receiving? Let me see. Is the picker here? The picker, can I see you on the call?
Yeah.
Okay. So the picker, as a consultant, as a consultant, what would you like to be told if you are not seeing the CTG and you are busy with something else?
So I would like so she's already told me the history about this lady, what she presented with: reduced movements, post dates, no stimulation on the CTG, possibly the description of a CTG if it's a flat trace. And if it is chronic hypoxia, is what, if I've been told the variability is poor, that would be the first thing that would be a red herring for me. So I would catch it if there's poor variability, rising baseline. Absolutely, this baby is in a lot of distress. So it is absolutely imperative to deliver this baby. So I would like to know from the registrar what the baseline is, what the variability is, and how much the woman is contracting.
Okay, very good. So for the trainees on the call that are probably the ones likely to escalate is, the picker would like to know how the CTG looks like and if she's in labor or not. Because if there are contractions, it means that the situation is evolving. It's not someone that comes with zero contractions and whatever happened before. This is a situation that is evolving. So not doing nothing or waiting is a decision in itself, because the clock doesn't stop. For the ones, let me just admit, for the registrars on the call, do you have the same perspective if it's the midwife or the junior doctor, the SHO, calling you? I'm just gonna say, one of the things that sometimes the non-scientific descriptions of the CTG, like suboptimal, flat trace, we should try to move away from that and give it a name and commit to it something, to say, I'm worried because it's suggestive of chronic hypoxia. I'm worried because it might be an abruption. And then you can come to describe what you see, because that triggers the decision to what comes next. Yeah. Any comments? Anything that you want to discuss about escalation? And do I have? Was Joe? Joe, are you still there?
Yeah.
Joe, let's say that you go and you describe the CTG, or you call the registrar, and the registrar is very busy in theatre. What would be your action then?
Well, I have 2 registrars, so I just go to my other registrar and everything would be fine. But if I mean, this is obviously at 6:50 in the morning, so there's probably not going to be a consultant about.
Yeah.
If they're busy in theatre, I'd probably wait until there's like a pause. I could quickly discuss the case with them, maybe show them a photo of the CTG on my phone. And if they say, yeah, they need to go for a section, then could start prepping and informing people while we're waiting or something.
Mm-hmm. Would you call the consultant?
I'd ask the reg if they thought I need to call the consultant, but I think at that time it's unlikely to be the case. I mean, it depends what's happening, obviously, but
yeah.
I wouldn't call the consultant without asking the reg first.
No, I think that asking the reg first is a good idea. But what I want you all to feel empowered to call whoever is needed, including the consultant that is in bed or having a shower at 6:40 in the morning. Because this is a situation where you need an action, and also what could you be doing, in advance? Take the CTG and send them for a walk.
You could get bloods and access, and but I probably wouldn't start consenting her and stuff until I'd had a decision from a senior.
Yeah.
Or informing anaesthetist and stuff until I'd had a decision from someone higher up, probably.
Very good. You did mention one thing. You were worried about 2 things. One was infection, the other one was abruption. So it's also to kind of think ahead. Yeah. So it's very interesting that, we are mixing a lot of science. We made a diagnosis, or we have a few hypotheses on the CTG. We have the impression that this baby is not well. We know that something needs to be done because this baby is not fit for labor. Yeah, we did almost gone through our checklist. But we've seen is 6:40 in the morning, the time where, changing of teams. The midwifery team is changing at 7. It's the end of a night shift. The registrar is in theatre. what I want to make sure is that escalation is just not passing the information. It needs to be a cycle. So it needs to be a response back. So if you don't feel that you don't have response, you need to continue. There's no good to say, to write on the notes, escalated, and then nothing happens. Yeah, it's like, oh, I washed my hands, I have escalated, now it's nothing to do with me. Until you see action, there's no escalation. The escalation is two-way communication. Okay, very good. So if we go through our checklist, can someone remind everyone what is on our checklist? What is the first thing? No one is. Is the baseline appropriate for gestation or for this baby? Is the variability normal and cycling? Do we see accelerations if there's no labor? Do we see any shallow decels? Good, sorry. I thought it was important to speak about the communication and the escalation bit. Ahmed, all yours. I'm wondering to see what happens next. I'm hoping to know what happens next, but
So, Joe, just like you had planned, while we're waiting for the registrar to come, the team decided, let's get the IV access in, let's send the bloods, because we don't think this baby is fit for labor. Yeah, we're just giving a couple of minutes. The registrar is just leaving what they're doing and is coming. Can we do anything else while we're waiting? I mean, remember, she was contracting 6 in 10. Can we do anything about that?
If we're worried about abruption, we wouldn't want to give terbutaline or anything. So
that's great. That's a very, very good answer. Yes, thank you. So this lady's contracting 6 in 10 for a reason. She's very early in labor. This looks like a chronic hypoxia. It may be an abruption. If I give terbutaline, I'm not going to make this baby any happier. Okay, I may actually make this abruption much worse. So no terbutaline, and it was not actually given. So the registrar arrived at around 7, and this is the trace. So we have been grilling you, Joe, but Fatima has come to save you finally. Fatima, you're the registrar on now, and you are the decision maker. What's your plan?
The plan is for a category 2 cesarean section, but to let the anaesthetist know that I'm concerned about chronic hypoxia and therefore not to whack in a high dose of spinals, give some fluids before to not drop the blood pressure further. And I would want the neonatal team on standby at the time of delivery.
Okay. Why category 2 and not category 1?
Because with a category 1, I feel like there's a lot of drama and the anaesthetist can get a bit excited and drop the blood pressure, and then it just leads to a poorer outcome.
Okay. But the problem when you're saying category 2 is category 2 can take up to 70 minutes, no?
Yes, but it's a category 2 where I'm wheeling them into theatre myself.
Yeah, so it's an urgent category 2.
I think that's very interesting, Fatima. And sometimes we are kind of all these categories, they were done for audit purposes. You know, when that's the only reason. There's no evidence that babies last 60 minutes or 30 minutes, even in a category 1, depending on the reason you are doing it, you may have 5 minutes or half an hour or 40 minutes. So I think that the importance is that we communicate clearly with the anesthetist what are we worried about, and this is as soon as we can do this section safely. So I think that, again, the language can trigger the team, because if you say category 2, they will relax. Oh, Fatima is not very worried. And if this was a chronic hypoxia without contractions, in honesty, probably nothing was going to happen in an hour or so. But if this is an abruption, that we said we don't know if this is an abruption, or if this is a chronic hypoxia with ongoing uterine activity, then the clock is ticking. Yeah. So this needs a very proactive approach. You did say very, very nicely about the conversation with the anesthetist, and these babies that are on the brink, we don't want to add further stress, like dropping the blood pressure, which reduces perfusion to the uterus, and the importance of having the neonatal team on site, and to have, ideally the most senior at the time, or at least to have kind of a that chain of communication well informed. I think that Mukta has a hand up.
Yes, Ms. Pereira, I just wanted to add that it's a good point of accelerating as CAT2, which is, we also sometimes say early CAT2, which we have to deliver the baby in 30 minutes and not 60, 75 minutes. But the handover time becomes quite a very complicated situation where teams are changing and they're wanting to see and delay, delays can happen. So to escalate, to tell everyone how quick we wanted as a surgeon to deliver the baby, it was taken as a category 1 section, and also depends upon the anesthetist. Like if anesthetist feels that they can't get the spinal in within the time, then that will also make a decision about general anesthetic versus spinal. And we did have a discussion that we don't want, so they did give her preload of fluid before giving the spinal. And with chronic hypoxia, when the trace is such, we don't know for how long it's been going. And by looking at it, delivering the baby as quickly, I think is worth if it's not changing in variability, just because we don't know whether baby's journey is towards the end or in the middle or in the beginning of chronic hypoxia. That's what I just wanted to add.
So, very good point, Mukta. The problem, one of the problems with our communication with theatre staff, that theatre staff can feel or can understand why we want to do a cesarean section urgently. If you are getting to the habit of calling everything after 7 o'clock a category 1 cesarean section, you will end up with a problem with then, well, they don't actually believe us anymore. Okay, I understand. I can see your point, but that was one of the downfalls in 2 of the hospitals I actually worked in the past, because people used to call category 1 cesarean sections so often that people stopped responding to them appropriately. But clear communicate. I mean, I would have probably said similar to Fatima. It's a category 2, but it's an urgent category 2 because this baby is unwell, and communicate about fluid resuscitation. Our service should not be affected by handover time, and our communication should not be affected by handover time. I can clearly say I can't hand this lady over. She can't wait. She's a category 2, but she needs an urgent category 2. That basically means she's not going to wait for handover, and the team would appreciate that, because then they know that they're going to have to go through with it, rather than crashing. Because as Fatima was saying, that can create a lot of drama as well. Does that make sense?
I just want to add few things, because I have a Divan NBT. Category 1 is delivery within 30 minutes, right? Because this trace this baby has chronic hypoxia. It is hypoxic, and it does need urgent delivery. So it fits into the criteria of a 30-minute delivery interval. And that was absolutely important, because I know this is anonymous, but this is what I was on call that day, and this was discussed with me early hours of the morning at 6:30. And just looking at the trace, you would feel, why would somebody who's 41 weeks, healthy baby on board, come with reduced movements? There has to be a reason. The placenta is not working well, the perfusion has suffered, and therefore the variability has gone off. Also, the baby is trying to compensate with rising its baseline. So all these factors are there. So baby is now at the end stages of getting tired. So at this stage, the baby doesn't go back. So it's not going to have an overshoot or correct itself, because it's already exhausted all its reserves. So that is one thing that the most primary thing that you need to keep in mind. So this baby, whatever you do, is not going to recover. It's towards its end stages, and before it gets absolutely to no man's land where you cannot bring it back, you have to deliver it. Keeping that in mind, you must, if you say a cat 1 section is appropriate for this particular trace, I'm saying, I'm not taking into consideration the handovers and what happens with the admin thing around change over time. So this baby does the delivery within 30 minutes, and you have to discuss with your anesthetist when you make that decision in your mind whether the anesthetist 1 is capable to give you a spinal within 10 minutes so that you proceed with the section and have an interval to delivery time of 30 minutes, or even less than 30 minutes, I would say in this case. Or if the anesthetist is, if there's an anesthetic registrar who says, no, I can't do a spinal within 10 minutes, that's fine. Proceed with the GA, but get the baby out within 25 to 30 minutes, I would say. And for this particular case of traces like this, I would say within 30 minutes. So 30 minutes is the maximum you can leave them in. Just wanted to add that, Susanna, because I've got the Diban MDT, so I'm just going to carry on with the MDT.
I do completely agree, and I think that we are a little bit muddled into this category 2, category 1, because we are basically all agreeing on the same. We should deliver this baby as quick and safe as we can, and we shouldn't be thinking that the handover is stop it, but the fact is that it interferes with the workflow in the unit. And if we say category 2, and although you communicate, even if you communicate with the matron or the anesthetist, or this is a category 2 because, but I want to do it as quick as possible, there's like a conflict there. And what is going to pass to the rest of the team is 2. So then what can happen is a cascade of things, because it's 7 o'clock in the morning. You remember the midwives, they change at 7 o'clock. So there's a change of shift, and there's the natural human, oh, if it's a category 2, it can change for my other person that is coming and it's just 5 minutes late. And before you notice, it's been 30 minutes and nothing is done. And there's one important thing here. We are saying chronic hypoxia, but we did say if this is a chronic hypoxia, it's a chronic hypoxia with uterine activity on top. And the other hypothesis we said, this may be an abruption, which is, again, uterine irritability with a baseline that is completely no variability. Whatever it is, it needs action quickly. I think that in these situations, don't be muddled with 1s and 2s. You can discuss that, be very clear that what is the action and how quick you need to have this delivered done. And just to go back on, the temptation of terbutaline to move, because there's a bit of delay, give terbutaline, please don't, yeah? So terbutaline, outside the use of oxytocin or prostaglandins, it's almost a no-no, yeah? So, because again, this uterine irritability is giving you another important tip of the severity of the situation, whatever is abruption or chronic hypoxia with early labor. Do you want, I'm going to ask, the registrars are very quiet. These things of communication are really, really important. Acknowledging the difficulties in a unit during the handover times, the communication with the anesthetist, with your team, passing the, what is in your thoughts, and you don't need to know everything. At this point, I don't know if this is going to be a concealed abruption or if this is going to be a baby that has chronic hypoxia in meconium, and, I don't know. I don't know if this is going to be a 4-kilogram baby with an abruption, or if it's going to be a 2.5 or 3-kilogram baby with chronic hypoxia. But one thing I know, and that's what you communicate very clearly, and you also say, I don't know, because I don't know, it means that sometimes you need either to ask or to act to cover all the possibilities. Is this making sense? I would like a comment from the registrars. You have been there, I know. not this one, not this case, but in these situations, handover times, end of a busy shift.
Yeah, that makes sense. That's a good summary, I think.
Okay, thank you. I'm curious. So, decision for cesarean section as soon as safely as possible. What is the next step, Ahmed?
So communicated with the anaesthetist about fluid resuscitation so that we don't drop her blood pressure. And so this is the CTG just before they're starting. It looks like there's a big drop just before they're starting. The delivery of baby was at 07:39. And it was a live-born female infant weighing 3.47 kilograms with thick meconium. What do we expect the baby's outcome to be? Given that this is what the baby's trace was just before delivery.
So I'd expect the baby to be born in poor condition and need initial resuscitation.
Okay. Do you think baby would respond to initial resuscitation?
I think as we've said, that whatever process has been going on, it's been going on for a while. The response will in some way be determined by what the underlying cause is. So if this is an abruption and it's been going on for maybe an hour or so, you might see a slightly quicker response with initial resuscitation. If this is a sort of combination of insults, hypoxia, possible infection, then I think that no, you're probably going to see a prolonged resuscitation.
Okay. What would you expect the pHs to be like?
I think that based on the CTG, I would expect the baby to be acidotic because we've already seen decompensation, and then there's evidence of a final sort of acute insult on top of that, and so I think it's difficult to say numbers, but I think it would be an acidosis, and I think it would be predominantly metabolic in the blood gas.
Any other takers? Anyone else want to guess what the outcome of this baby is going to be?
Ahmed, I presented this on Friday, so know the outcome already. I don't want to spoil it.
Thank you. Okay.
I agree with Teddy's.
You agree with Teddy? Okay. So the answer I would say is, okay, I would expect this baby to be born in a poor condition. However, I can't comment upon how this baby is going to respond to resuscitation. Because if you go back and look at the trace, this baby has not been telling me pretty much anything at all. This baby has been unresponsive. Unresponsive can be that this baby has become unwell right now and it's unresponsive right now. So it had just very reduced reserves. And the query abruption or the frequent contractions have basically just knocked it off, and it's now not responding right now. And it is falling into hypoxia. Or it can be that this has happened over the last couple of days, and this baby has been unresponsive for a couple of days, in which case this baby is not going to be very hypoxic. If this baby is becoming hypoxic right now and it's just become unresponsive right now, this baby would be flat, and once you start resuscitating, it may pick up quite fairly quickly. But if this baby is unresponsive and it's been had this chronic hypoxia and unresponsive for a couple of days, it's not going to pick up that quickly. Okay. Similarly, the pHs, if it has been chronic hypoxia for several days, it's actually going to be fairly within normal range. But if it's an insult that's happening right now, it might be acidotic. Does that make sense? It is going to depend upon baby's compensation. And now, from the CTG, I have no idea how this baby is compensating. Okay. Similarly, how the outcome of this baby, as in baby's brain insult, I would answer, I say, actually, I don't know. I hope that this baby is just losing responses right now and I can resuscitate and this baby ends up with no long term. However, if this is since we have seen the baby today, this baby has not given me any signs that it's good. So if this has been going on for several days, this baby might be very unwell. And I think this kind of communication is very important to the lady herself to know what to expect. Women are happy to accept gray areas if that's what we have. I don't want to be telling her I'm crashing for a category 1. I'm expecting this baby, that I can save this baby if I actually can't. Does that make sense?
Yes.
Yeah, so I think that it is very true that it's very difficult to predict in chronic hypoxia. And we have seen cases where the babies do very well, and cases where the baby they have very long-term problems. And because when we see them at the time of decompensation, we can't say how long it has been. For this baby, however, anytime you have chronic hypoxia and you add contractions or an acute or subacute insult, then they tend to have a lower pH. But again, it's very unpredictable. So that's why we want the anesthetists on board, and the pediatricians on board.
So this baby came out flat, as we all predicted, as you predicted, Teddy, and then picked up fairly quickly. And the gases were showing that it was acidotic, as you predicted. I'm not entirely sure if these are paired gases, just because they're too close in all numbers. So I think they might be coming out from the same vessel, but I can't swear on that. Okay.
What's the pH we are not seeing, Ahmed?
You're not seeing 6.9 and 7.
On my screen, I can't see it. Oh, now I can. Okay, there was a delay. Thank you.
Okay. So pHs are 6.9 and base excess minus. My baby was tachypneic at 11 minutes with a heart rate that proceeded to become less than 100 with low sats. It was intubated and surfactant administered, and the baby responded well to from its saturations. So all this actually tells me most likely that this was a baby decompensating as the lady presented or shortly before. Does that make sense?
Yes.
And the baby was diagnosed with meconium aspiration. It did not meet the criteria for cooling. It was transferred to St. George's, where they monitored the baby and noted a neonatal seizure at 18 hours of life. It received dilutional exchange transfusion because they diagnosed polycythemia, and then it was weaned off cardiovascular and ventilation support. EEG and MRI have not shown any significant findings, and there's normal neurological examinations. So it looked like we did manage to intervene at the correct time. Okay, and the baby was discharged home at day eight of its life. This is a picture from the histopathology of the placenta, which was showing that there is intravascular thrombosis and poor placental perfusion, and evidence of chorioamnitis on top. So, Joe, you made the diagnosis from the very, very beginning. Just within the first 15 minutes of seeing the trace. Well done.
Thanks.
Any questions? Any comments? Any learning points? I think what everyone is very quiet. I think that would be, the cases are as important as we can learn and reflect on them. What went well, what could we have done better, and anything that you take for your career and for your work on the labor ward. So can I ask one of you one by one to say, out of today's session, what is the one thing that stands for you and that you take for the day? That's Nia. You know this case well because I know you presented in the perinatal meeting. Thank you for that.
Yeah, I think what's really good, I think it goes back to the fact that obviously having looked through the notes as well, knowing what the initial fetal heart rate was in antenatal clinic. So I know although the initial heart rate was only about 150, you might not look at that initially and think chronic hypoxia, but there was such a rise from what it being 135 in antenatal clinic. So I just think the team that picked this up did such a good job to pick it up so quickly and have the baby delivered well, and I just think that's a really good learning point and something that I've certainly adopted this year. Is really important to go back and look through the fetal heart rate through antenatal clinic, particularly if there's no previous CTGs that the women's had, which in this case she hadn't, so that was purely picked up just on the antenatal listening in to baby.
Very good. Thank you, Mia. Mukta?
Hello, sorry, I can't speak.
Why not?
Fatima?
I'm so sorry. I'm also doing gynae on call, so I literally just stepped away from the phone for 5 minutes. So I missed what happened.
I think the point that's been made a few times is the fact that what was different about this case as a chronic hypoxia case is that the contractions were still ongoing. And so I think, we all look at the CTG and say, oh, the baby's decompensated because you reached that point of reduced variability. But I think the really important difference sometimes is whether, is whether or not that journey to decompensation has been sort of sharpened by things that are still going on. So I think it's, this particular case is interesting in that respect. It's a bit difficult to make a call because it's not as classic chronic hypoxia. And so, compared to someone who walks through the door who's having no contractions and then has high baseline reduced variability, you've got, a compromised baby, but you've got essentially a stable compromised baby where you've got more time. And so I guess it's just having a view of where you are on that journey and how things might evolve in the next sort of 30 minutes to an hour. And obviously, if there's abruption in the mix, is an idea that by the nature very unpredictable. And so, if she suddenly completely abrupts, then you've obviously you could lose the situation in a very short space of time.
Thank you. Very, very good point, Teddy. Joe?
Oh, thank you.
I think it was some important points about escalation and being able to escalate to consultants in situations like that. Was a learning point for me, I'd say. Yeah.
Remember that the consultants will always regret not having been called, rather than to have a team struggling, busy, and so I hope that you all feel empowered to escalate, even if it's to someone that is just in bed, because the advice nowadays we can share the CTG. I'm working to have the scan on the consultant's mobile, so even without the need to share through non-secure. So it's a way forward. Mukta, you are back. Do you want to tell us your learning points and your comments?
Yeah, I just wanted to say that it's always that when you're in another delivery and you're just told by the midwife or someone that there's a CTG with high baseline and reduced variability somewhere, and they're going to come around, just not to wait. And I think that's what I did. I didn't wait for them to get the patient to labor ward. And when I reached the birth center, I saw the patient was already on CTE for an hour. So I was like, if it had to change, it would have changed by now if it was not chronic hypoxia. So it's very important to just be proactive, and once you are just being told, just to let you know the patient is going to come around in 24 with reduced variability. So I think if you have to leave something, just cast an eye if you can, or send someone who can do it for you.
Thank you, Mukta. And I do think that don't, Joe, in terms of escalation, and don't be afraid to start, I'm worried. Yeah, because that triggers, if we give too much information at a time where people are overloaded with, lots of things, it's important to be very concise to say, what I'm asking you to do is to give me advice, or you actually want me to come and see it, or is it something that can wait until I finish what I'm doing, or are you worried and we need to do this now? So that sense of time and concern is very important in communication, so we can judge and prioritize without actually seeing the case. Excellent. Very good team. I'm so proud of all the all the work that, and it's really good to see today a little bit more people on the call. And thank you, Ahmed, to suggest to record it, because I'm a bit shy on camera, but I think that probably it's useful for the ones that couldn't attend today. Okay, enjoy the day. Do you want to say any final comments, Ahmed? Please be.
No, thank you. I'm okay.
I just want to congratulate for the quality of the slides, for the fact of having the history, the CTG, and the placenta is really closing the cycle, for sending the placenta and for bringing the results in. And the only thing I'm going to ask for the future, especially if we are recording, is to delete the date. Yeah. Just because
I will edit that out.
Thank you very much. Thank you. You have that magic powers on the computer. Fantastic. Thank you so much. Enjoy the day.